This is a young male with a posterior nodal cataract, and I will be showing how I went about planning and executing my plan in handling this cataract. As you all know, posterior nodal cataracts are a little more risky to get a deficiency in the capsule. Here, after placing my 2.8 millimeter incision and two side ports, I make sure I stain the capsule. Doesn't require staining, but always better to, just in case your pupil shuts down. And I am planning a vertically oval rhexis in this case. The idea behind this is, in case of a breach in the posterior capsule and you need to put a 3-piece IOL in the sulcus, you have the horizontal anterior rhexis flanges to support your 3-piece IOL, the sulcus. And that's the idea. Moreover, a oval rhexis also makes handling the cataract a lot easier. So I'm doing it with a cystitone. You can also do this with Uthrata forceps. Probably may have a little more control in such a cataract. And that's done. And once the rhexis is done, I am going to just do hydrodelineation. And with the delineation, the whole nucleus has come out. And I am just helping it with my hydrodissection cannula. I put a little bit of visco behind and a lot in front. I am on a low flow. My irrigation is down to 80 centimeters and I just aspirate. I will not place my second instrument unless I need to. And at this point I felt the need, and this is the idea behind this. There's no need to put in a second instrument and have a bigger risk of the AC collapsing on you. After this, very carefully I'm just trying to dislodge the cortical fibers towards the center. I'm just loosening up the cortical matter. I'm not trying to go across. Slowly after dislodging, I take it out piece by piece. However, in this case we don't have to be that careful because I already know that the PC is intact. Although the PC is intact, always remember it may be a little more weak than the normal cataract. So don't do sudden decompression of the chamber. Sudden fluctuations in the chamber is not a good idea in these cases. And hence, once I finish the cortical aspiration and the epinuclear aspiration, I go ahead and just leave my irrigation probe in, put in some viscoelastic so that the chamber suddenly doesn't collapse. I then put my single piece foldable IOL directly into the bag. If one wants, you can orient the haptics horizontally. It doesn't matter. I think it's pretty stable. And then I go ahead and aspirate all the HPMC from within the chamber. And also go behind and do a thorough cleanup. of the HPMC. I did come back. You can see the rex is nicely overlapping the lens. I did come back because I saw some, you can see on the left side, there are some cortical fibers on the posterior capsule, which I wanted to clean off. These are young patients and you really need to do a thorough job on them. Incidentally, this patient is in his late 20s. Once I have done that, I again leave my aspiration in, try to hydrate the ports so that it doesn't suddenly decompress. Putting in my intracameral antibiotic and conclude my surgery. Thank you for watching.